Good morning to all of you. Right. So, the 10 participants, great to see, right? Good. So, soon everybody will be joining. Till that time, what we can do is we can have a brief about what we discussed last time, yesterday only, right? So, anybody who remembers uh, the last batch of the students or last batch yesterday with what we have talked about specifically with respect to coccidiomycetes? Yes, anybody? There are Dikshit, anyone? Yesterday discussion, just only with respect to coccidiomycosis, right? Anyone who would like to add? No one? Why so? Like, nobody remembers what we have discussed last time? Anson, any updates from you about yesterday's session? Okay, so I think nobody is interested. Okay, great. I'm getting one particular caused mainly by imitis. Yes, Ronnie, thank you. At least you remember what actually was the name and what we have discussed yesterday, right? So thank you for that. Anyway, let us start with today's session. We may talk about yes, within coccidiomycosis. Yesterday we have discussed, and it was with respect to what can be the probable epidemiology because it is mostly there or observed in valley contents or valley, and that's why we are working mostly with respect to if we have name where it is valley fever, right? And mostly it is endemic to an eastern part or southern part of the America. So over there, that's why it is there. And then we talked about what is difference between blastomyces, dermatitis, and coccidiomycosis. So in both the conditions, we talked about that. And now we are talking about today with respect to mycosis, right? So the reason why I asked you is because you need to remember because we are trying to get a comparative what can be the probable comparison between them. So that's why we are trying to focus on the comparative analysis of that, right? Just a second. Sorry for that. There was one call regarding exam, so I need to take it. So yes, we are talking with respect to epidemiology. What can be the probable microscopic characterization of that? And today, what we are going to talk about, similar to the blastomycesis, coccidioidomycosis, one another strain we are going to talk about, which is called as an paracoccidiomycosis, right? Now, again, similar to the origin, it is from South American origin. So, overall, if you remember, we are talking in previous sessions that yes, everybody is politically talking about that corona is coming from China, and then we take one example that yes, we are much more better than China, that we are the generators of corona, but then America also start competing with us, so that's bad for us. And mostly with respect to systemic mycosis part, major of the disease which was there is due to an American origin, so they are also proud of that, that they are competing against the Asian origins or Asian countries, right? Now, with respect to origin, we come back to what actually the disease is. The disease is an chronic granulomatous, right? It is an again systemic mycosis part only, and basically it is caused by the name saprophytic fungi, uh, brasiliensis, right? Again, with respect to same like blastomycosis and coccidiomycosis, it is similar. It is a dimorphic fungi that it also resemble an yeast structure and also resemble an fungal structure, right? So it is there. So it is always growing as in tissues, and in tissue it always grow in yeast form, but always in a culture medium. That in culture medium it always remains in particularly a mold form. So in both the case, it works very well over there with respect to yeast form or mold form. With respect to epidemiology, and if we see the geographical distribution, mostly the geographical distribution is from Brazil, and that's why the name is Brasiliensis. Further, Central America, Mexico, but recent year it has been over again called it as an endemic, because mostly it is found in that particular region only, and it has not spread from that particular region. So might be the conditions are humid which are favorable over there for an systemic mycosis part. And further, if we talk with respect to different source of infection, it is unclear that how does it is transmitting, and if there is a specific source which is there, which is cause of transmission or source of infection or not. So that's why over here the exact mechanism by which it is transmitted or acquired is clearly unclear over here. However, it is speculated, just as in particular hypothetical speculation, that the spores are actually inhaled, and due to this inhalation, the organisms from the environment, due to this inhalation, it really transmit from person to person. But yes, this is only speculation, it is not true. If we see the mechanism of how does it enters and how does it penetrates and how does it propagates, mostly, first of all, the first picture as soon as the infection happens, it is an asymptomatic. We are not knowing that it is particularly an symptomatic or no, so mostly it is an asymptomatic. And further, it leads to an ulcerative lesions, right? That it causes some ulcers, and due to that ulcers in the mucous membranes, it causes some lesions over here. So that's why the mostly the preliminary site for this particular infection is pulmonary infection. However, If we want to detect it, the detection would be the specific ulcers or specific lesions occurs on a specific mucous membrane part. Further, these lesions can be observed in different parts of the body. Most or least commonly observed in conjunctiva, like in eyes, it is most less to be propagated. Yes, but it propagates. There are few cases, but the very less chances that you can easily observe in terms of conjunctiva. However, nasal and oral mucus, something associated with nose and oral cavity, over there it is common lesions which is actually and forming, and it is associated with it. So that's why we are not able to identify it. Okay, so ulcerative lesions are most commonly present in nasal and oral mucus. However, it is very less commonly present in any type of conjunctiva, right? Now, among all these nasal, oral, conjunctiva, the mostly, if we see with respect to highest frequency of infection, the highest frequency is associated with our oral membrane. If we want to characterize what can be the lesion characteristics, or how does we characterize through particular lesions, we need to understand these particular lesions are very just like an E shape, but at the end of the E shape or in the border of the E shape, it is very active, like an serpenous and crusted surface is there, right? So it looks like, and if you just bake the bread, right, what you see is you see a small or a crust over there, and this crust is usually observed near, particularly at the edges. So that's why always on during the crusted surface, it is observed over there, right? Now, even with respect to pathogenesis, the pulmonary infection, um, mostly chronic pulmonary infection is found in approximate 50% of the cases. If we talked about the dissemination, because there are three type of, right, one was an acute, one was particularly chronic, and then we called as a disseminated. So what we talked about, the pulmonary chronic part is 50% of cases. However, we talked about the dissemination part. In dissemination in another anatomic site like a lymphatic system, spleen, intestine, liver, meninges, adrenal glands, these are what we call as a disseminated particular part, where there are small infections are observed, right? But what would be the common signs? These are all what we call as when as the infections are spreading in the internal organs of the body, and we recognize, yes, this is the particular site where the infection is spreading much more. Now, what would be the common signs for it? The most common signs and symptoms would be like ulceration in the mouth. You will find there is a small ulcers in the mouth, nose. There is an draining in the lymph nodes, less skin lesions. That is most common part, something what we call as in skin lesions. And what it leads to, the initial symptoms can be continuous coughing. Further, it is followed by weight loss. Even though you take a normal food, you take normal diet, then also you will see there is an weight loss which is there, and it leads to, and sometimes fevers also. But this, however, the fever, we cannot say that it is exactly what the fever is, right? It can be in particularly combination of uh, different particular uh, infections, right? And that's why we cannot say it. Now, what can be the probable laboratory diagnosis for it? So probably the laboratory diagnosis is same as we do for previous fungi, that we go for an multiple budding yeast forms serologic test, and over here the direct examination can be done using same KOH. But what we need to take as a sample, we need to take sputum, mucosal biopsy, and other exudate as a sample. We need to dip in 10% KOH, and we need to observe what can be the probable colony characteristics or morphology of the yeast. So usually yeast appears large, round to oval, measuring 10 to 40 micrometer in diameter, and that's how we observe it as a direct microscopy observation. However, it is in resembling what we call as in sip will be seen under a microscope, right? It is looks like an sip wheel. What would be the colony appearance once we culture it? These colonies, if we want to grow in a mold form, like in fungal form, it grows very, very slowly. It will take near about 21 to 28 days, and what it will be, the appearance or colony morphology would be somewhat wrinkled, moist appearance. So something what is wrinkled and moist appearance. And with respect to mycelial phase, it is leathery colony. With maturation, the spores gives the pigment which is an tan brown. And if we talk with and compare the aerial mycelia, the aerial mycelium of this culture is very, very short compared to another particular culture which is growing on an potato dextrose or sabrodextrose agar, right? So there are three characteristics whenever this organism is growing on an potato dextrose agar. One we call as a leathery colony. Second one, it turns into a particular brown with respect to age. Third one, the aerial mycelial part is very, very short. So this is what we call as a mycelial phase. And if we talked about the yeast phase can be observed whenever we used again the brain heart infusion media, or what we can use only blood agar also. The colony characteristics of yeast becomes cream to tan, very, very moist, and a wrinkle colony. It turns into a waxy, so it turns into waxy, wax-like structure with respect to age, right? So this is what we call as a difference with respect to colonial appearance, mycelial phase, and yeast phase whenever we culture on a specific media. Now, once we culture this into a specific media, how do we identify it, right? How do we observe it microscopically, or what can be the probable identification for it? So if we talk about the mycelial phase, it looks very, very small, septate. And if we talked about the conidial structure, the conidial structure would be an chlamydia, right? So there would be an intercalary or terminal chlamydia. And with respect to yeast phase, it has a multiple buds associated with it, and it is always attaching to the mother cells, right, by a neuroconstriction, and that's why it is what we call as a ship wheel. The serology test is same what we have discussed with respect to blastomycosis and conidiomycosis. We need to go for an immunodiffusion. It works with a very, very specific antigenic site over here, and it is proving a very, very valuable tool for identifying the fungus. Then after conidio, basidio, conidiomycosis, now it is something what we call as a histoplasmosis. Now histoplasmosis has a peculiar name, what we call as a Darling's disease. Right? It, in another particular scientific terminology, it is also called as an reticuloenthelial cytomycosis. What it is called? Reticuloenthelial cytomycosis. It is the most common type of systematic mycosis, apart from if we compare with respect to blasto, with respect to conidio or coccidiomycosis. This is the most frequent which is happening, and it is usually again appearing in or appears in a dimorphic form, right? It usually appears in a dimorphic form, so we are not able to understand where the actual system would be. So Dimorphic form can be in classic form or in small form, and usually there is particular connection with African continent. So the name has been given the histoplasma deboisis. Now on Sebrodextrous agar, it changes its dimorphic form whenever you grow the culture in a room temperature. So that's why, because of its dimorphic form and due to its larger form compared to blastococcidiomycosis, comparatively very large in the structure, this would be easily to identify, or it can be used for easy identification, right? So that's why hypophere, both large and small for spore form, which is always used for identification. Now, why it is called as a darling disease? Okay, because it was not something associated with any type of what we call as an and particularly specific nickname, but because one of the scientists' name was Samuel Darling, that's why it was called as an Darling disease, right? So Darling is the particularly surname of Samuel. So Samuel Darling has discovered histoplasma capsulatum in around 1900s only. So it is not an too old disease to understand. In 1900s, he actually found this particular, that this is the responsible disease for systemic mycosis, and he named this organism because he misunderstand it that it is an encapsulated animal parasite. However, because it is an saprophytic soil fungus, obviously at the some further stages it became clear that it is a non-capsulated form. So it becomes a non-capsulated saprophytic soil fungus. And what would be that it is usually caused by an histoplasma capsulatum, which shared many characteristics with an coccidioidomycosis, right? So that's how we can identify that what is difference between it. Now, if we see the spectrum of disease caused by blastomycosis, coccidiomycosis, histoplasma capsulatum, the spectrum usually does not limit with self-limited. It also gives normal asymptomatic infection to chronic infection. So this is the organism where the characteristics of organism become very dangerous. Now, why it become dangerous? Because usually either it can be in very less infective, or it can be in very highly pathogenic. But how about any specific range of the organism where the organism is causing disease, it is infecting the disease, and it is becoming chronic also? Now, the worst thing about it, it is chronic, it is in less common infections within the same particular human origin, and human origin, it is sometimes it is specific to the gender male only. So that's why it is very difficult to like identify or recognize it. To add to its worseness, uh, this disease usually occurs worldwide. It can be spreaded worldwide, right? So that's why we need to understand it. Then we talked about what is an epidemiology and geographic distribution of it. The geographical distribution, it occurs in all the parts of the world, mostly associated with an Great Americans, right? So it is also associated with US, and it was somewhat also correlated with some of the African subcontinents, right? Now, what would be the ideal source where we can find? Would be the ideal source would be wherever the birds or bat are actually cropping or enriching the soil nutrient over there actually. it will be there. So that encourages the growth for it. Okay. Then where the maximum accumulation of this organism is found, the maximum accumulation is in the soil which has been enriched with the nitrogen, right? Which is very enriching with the nitrogen, and that encourages the growth of histoplasma capsulatum. So those soils which are actually having a nitrogen rich component, or can be in particular higher source of histoplasma capsulatum. Then the another particular species of same genus histoplasma, what we call as an histoplasma duboisi, it occurs in a tropical Africa continent, and it is referred to as large cell histoplasmosis. The only reason is because difference with respect to the size of the yeast cells, and what it can be that intracellular yeast cells can further cause much more infection compared to histoplasma capsulatum. So due to its larger size, right, it has been given, and it is called as a large size histoplasmosis. If we talk with the source or sample source similar to histoplasma capsulatum, it is something which is acquired through inhalation by an infected unit from the environment. So it is same source with respect to histoplasma capsulatum. And if we mostly with respect to, again, the nitrogen enrichment in the soil plays an important role with respect to the continuation of life cycle of histoplasma in that particular soil itself, right? If we want to see what can be the particular pathogenicity associated with it, infection begins with very small or primary function or lung infection, much more looks like an initial particular part of tuberculosis. So very early stage of tuberculosis, similar to an primary focus of lung infection, is over there. And what can be the causative agent of that? The causative agent can be with respect to like an alveolar macrophage which is there in the lung. Now these macrophages which are there associated carry the fungi, and further fungi spreads in the body. And then the worst thing that it circulates into an blood. It starts circulating in the blood, from which it has an other organs or destroyed by the body defenses. So that's why usually it works with an pathogenesis part, that it is usually destroyed by the body defenses. Now, so initial lung infection, it can be easily observed. However, there are only 5% is there where you can easily observe the lesions. 95% you cannot are something what we call as an asymptomatic or very mild infection, right? So initially the common symptoms are very looks like cough, fever. But if we go for an like x-ray or nowadays CT scan, then we are able to identify what would be the actual cause of it, and more areas of pneumonitis would be there, right? So with respect to that, if we again go for its identification or characterization, we need to observe the continuity of the particular human being. Now continuity would be over weeks or months. You need to continuously observe the body of the patient. If there is a continuous production of the cough or coughing is too much, followed by weight loss, even high nighttime sweats, then it can be with respect to what we can further identify that yes, this can be the probable, particularly chronic pulmonary histoplasmosis can be, right? Further, if we talked about the acute disseminated histoplasmosis, it can be mostly mistaken or can be correlated with miliary tuberculosis. And that's why the common findings would be like fever, jaundice. It is in association with another particular species. So that's why we cannot easily identify that, yes, it is due to this specific species or not. It can be with respect to association with another species also. Now, under such cases, individual either remains in an acute phase, so acute disease are there, and then chronic cavitary disease, what we call as severe blood-borne disseminated disease are there, right? The only thing how we find it out is through observation of patients gradually over the weeks. If we are continuously observing an mild cough, and if there is an reactivation of some of the lesions which has initially observed during the infection, then suddenly cavitation has become frequent. Now these all are the sign of tuberculosis, but whenever this happens, if you go for an initial identification or through scans, different scans, then and then only we will able to separate or we'll able to identify what is the exact cause of such disease. So that's why we are not able to correlate what can be the probable correlation between chronic pulmonary tuberculosis or another specific disease. If we talk with respect to disseminated part, so disseminated histoplasmosis is somewhat what we call as in reticuloendothelial system. So one was what we call as in Samuel Darling disease. The another that was in chronic part. The another part what we call as in disseminated part. So disseminated part what we call as in reticuloendothelial system, and that's why because the most of the lesions are observed in this reticuloendothelial system, it is what we call as an disseminated histoplasmosis. However, if we see the percent of infection of this particular disease, it is very, very rare, and usually it occurs in an immune suppression person. So with respect to immune suppression person, it is observed, and patients with respect to different viral infections have some particular immune defects, have some particular cancer. So we will not able to identify that it is due to particular mycosis or it is just due to any type of an viral infection, right? However, it in children or younger age children also it has an reticuloendothelial defect is there. So that's why what we call as an Flecklian disease in childhood is observed. If we want to observe laboratory diagnosis for it, direct examination is possible, but it is unsatisfactory that we cannot go for direct microscopic observation. Is that yes, for initial observation we can go for Giemsa staining, right? We can go for Giemsa staining of that, and then what we see that in yeast can be easily observed in a mononuclear or endothelial cells. Further, what can be the particular size? So if we talked about the histoplasma capsulatum, it is near about 1 to 4 micrometer, and if we talked about the histoplasma deboici, it is 7 to 15 micrometer in diameter, right? So usually the histoplasma capsulatum, it is mononuclear, and if we talked about the histoplasma debocoi, it is much more appearing as a nucleated part. So this may be difference. So this is what we call as an histoplasma looks like in Giemsa staining in an yeast form, and histoplasma capsulatum is in mold form. Complex particular hyphal structures or mycelium segments and association of spores with it. So that's why the complexity over here and complexity you can see over here would be mold and particularly yeast phase only. If we want to culture it for better identification, it because it is dimorphic again, it is observed in mycelial phase also and in yeast phase also. However, it takes near about 2 to 4 weeks to grow, and usually the mycelial or yeast colonies appear at particular temperature 25 to 30 degrees Celsius, right? So with respect to that, with respect to temperature, if we keep at 25 to 30 degrees Celsius, it is usually observed. And with respect to mycelia phase, on Sebroglucose agar, the colony morphology. Okay, Nelson is asking one question: is there any known mechanism of histoplasma cause the lesions of the skin? Yes, specific skin lesions is observed. With respect to mechanism, there are different particular genetic mechanisms behind it. With respect to just if we compare with the blastomycosis and with respect to coccidiomycosis, over here the will come across what would be the skin lesions or skin particular infection on it. And if we talked about the yeast phase, you can see it. Okay, yes. So this is what I think Nelson was asking. Because of extensive cross reactivity with respect to fungal pathogen, we need to have a specific humoral antibodies. So if you remember, there is a specific K antigen for blastomycosis dermatitis. Over here, instead of, because there is an extensive cross reactivity, we are not changing the antigenic site, but over here we are changing the particular antibodies. So we are targeting a specific humoral antibodies, and that's how we identify that there is a skin infection is present or not, right? There are particular same complement fixation tests, latest agglutination test, and this is how actually imitis dermatitis, histoplasma capsulatum, and Paracoccidis brasiliensis looks like, right? So what would be the summary? We understand the list of pathogens that cause systemic mycosis. Yes. Thank you, Nelson. And then what can be the particular source of infections? And what are the different forms, two forms of pathogenic fungi where they can be found? And there are three different forms of systematic mycosis and what they makes them different, right? So overall, we are able to answer all these questions of with respect to systemic mycosis. If you want to go for references, there are a few references over here which has been highlighted. So for with that, what we are ending, we are almost end with respect to fungi infection part, that how the fungal infection is there and how much fungal infectivity is there. Okay, so I hope you are able to understand. I will upload the slide of cutaneous, fungal, superficial, all the type of mycosis. Mostly it will be helpful. Right. So if we are talking about that, mostly I think it would be helpful with respect to initial part. Okay, so with that we stop our today's session, and I will upload it. What I was saying, I thought I lost my connection, so I will upload the material, and mostly it will be useful for the examination part also. And then in our next upcoming sessions, we will start with the viral part. Okay, Nelson is asking, is there any updates regarding exam, offline classes and practicals? Devi is saying, would you please upload the book chapter for fungal infection? Sure, Devi. Yes, Nelson, for exams are definitely going to be offline only, because mid semester one students mid semester 2 is going to arrange offline only, and their finals are also offline only. So for you also the same will be applicable, that exams are going to be offline classes and practicals. Soon it will be started, hopefully by as soon as if any update comes, but I'm expecting by first week of February. I'm not sure about it, but I'm expecting that it would be great if we can arrange some offline sessions and practicals also. it would be great for us. So we are trying that, I am trying that, and I am expecting it should start by 1st of February or so, but let's wait for the exact notification from the higher authorities, right? And rest I will also upload the book chapter for fungal infection. Okay, okay. Thank you all for attending the session. It was great.